It starts so quietly you almost miss it. A little heaviness, a little pressure. Maybe you think, I just haven't gone today. It's fine. So you go about your morning. You drink your coffee. You sit down on the toilet, and you wait. Nothing. You try again an hour later. Still nothing. You shift, you strain. You tell yourself it'll pass. But it doesn't pass. By the afternoon, something has changed. There's a dull, deep, almost throbbing ache radiating from the pit of your lower abdomen, creeping into your lower back, spreading down into your pelvis. You feel bloated, uncomfortably, unnaturally full. Your appetite disappears. You feel strangely warm, slightly feverish, and a quiet voice somewhere in the back of your mind whispers, "This isn't normal." And here's the terrifying part. That voice is right. What you are experiencing in that moment is not ordinary constipation. It is not something a glass of prune juice will fix. It is not something that will simply sort itself out if you wait long enough. What is actually happening inside your body at that moment, right now, perhaps as you watch this, is a full mechanical blockage, a hardened, compacted, rock-solid mass of waste that has become physically wedged inside your rectum. And if you do not know exactly what to do next, if you make even one of the common mistakes I'm going to tell you about today, that situation will escalate into something genuinely, life-threateningly dangerous. I'm Dr. Franklin, and in the next 30 minutes, I'm going to walk you through everything your doctor never told you about this condition, what it is, how it happened, how to recognize it, what to do right now, and how to make absolutely sure it never happens to you again. Stay with me. Every minute of this video matters. What is actually happening inside your body, 2 to 6 o'clock? Let's start with the biology, because once you understand what's happening inside you, everything else will make complete sense. The medical term for this condition is fecal impaction, but forget the clinical label. Let me describe what is physically occurring inside your digestive tract in plain language. Your large intestine, a muscular tube roughly 5 feet long, has one primary job: to absorb water from the waste material passing through it. And it is extraordinarily efficient at this job. It never stops, never rests, never pauses. The problem begins when stool stops moving forward through the colon. Maybe it slowed down for a day, maybe 2 days, maybe more. But as that stool sits there motionless, your intestine continues doing exactly what it was designed to do, pulling moisture out of it hour after hour, day after day. What began as soft, manageable waste gradually transforms. It stiffens, it compacts, it dries, and eventually, it hardens into a dense, dehydrated mass that is roughly the texture and consistency of hardened clay or dry cement. Now it's stuck, physically, mechanically stuck. And here's the part that traps people. Think of your lower intestinal tract like a garden hose. Inside that hose, there's a large, jagged, rock-solid obstruction. Now, what happens when you push harder, when you strain with all your strength trying to force it through? It doesn't move. It wedges tighter. The harder you push, the worse the situation becomes. That is exactly what is happening on your toilet when you strain, with everything you have and nothing comes. You are not helping. You are compressing the blockage further into position. And here's a critical fact that most people do not understand. This almost never develops overnight. This is a slow, quiet, creeping emergency. It builds over 3 days, for days, sometimes an entire week. During much of that time, you might feel only mildly off, slightly sluggish, a little full. You might even still be passing small amounts in the bathroom. But each time, only a fraction of what your body needs to eliminate is actually leaving. A portion remains. The next day, more stays behind. The day after, more still. The pipe is narrowing. And you don't feel it happening until it's almost completely sealed. Why this happens more after 6 to 9 o'clock. Now I need to speak directly to those of you who are over the age of 60, because you are at significantly higher risk for this condition. And the reasons why are not your fault, not even slightly. After 60, your body undergoes a set of quiet, overlapping physiological changes that together create the perfect internal conditions for fecal impaction. First, The muscular contractions of your intestinal wall, the rhythmic, wave-like squeezing called peristalsis that pushes waste forward, naturally slowed down with age. The engine gets quieter. The waves become weaker. Waste moves more slowly. Second, your pain perception inside the gut becomes less reliable. The nerve signals that would normally tell a younger body something is wrong, pay attention, become muted and delayed. You may not feel the warning pressure that should alert you early. Third, the medications that millions of older adults take every single day, blood pressure medications, pain relievers, antidepressants, iron supplements, calcium tablets, many of these significantly slow intestinal movement as a side effect. Nobody told you. It's buried in the fine print. Fourth, your thirst reflex weakens. This one is deeply underappreciated. By the time you are in your 60s or 70s, you may be chronically, consistently dehydrated without ever feeling thirsty. Your body's alarm system for fluid loss has lost sensitivity. And since hydration is the single most important factor in keeping stool soft enough to pass, this silent dehydration is constantly working against you. These four things happening simultaneously: slower motility, dulled pain signals, constipating medications, and undetected dehydration. That is the storm. And most older adults are walking right through it every single day without knowing. Again, this is not failure. This is biology. And now that you understand it, you can fight it. The symptoms that trick people, 9 to 1400 hours. Here is where I need your absolute, undivided attention. Because the symptoms of fecal impaction are deeply misleading. And misreading them leads people to take exactly the wrong actions. Actions that make everything dramatically worse. Misleading symptom number 1, watery liquid discharge. I know what you're thinking. I can't be blocked. I have diarrhea. Listen carefully. When a solid, hardened mass completely blocks the rectal canal, the newer, softer waste coming down from higher up in the colon has nowhere to go. So it is the only thing it can. It seeps around the edges of that blockage and leaks out as thin, watery liquid. This is called overflow diarrhea or paradoxical diarrhea. And it fools people every single time. They see the liquid output, and they reach for an anti-diarrheal medication, something like loperamide, and that is one of the most dangerous mistakes possible in this situation. Anti-diarrheal medications do not just stop the leaking liquid. They slow and suppress the entire digestive system. The impaction continues to harden. The blockage grows. The window for safe intervention narrows. If you are experiencing watery discharge combined with a heavy, aching sense of rectal fullness, do not touch anti-diarrheal medication. Not a single tablet. Misleading symptom number 2, difficulty urinating. This one surprises almost everyone. You feel the urge to urinate. You walk to the bathroom, and what comes out is a painful trickle, or nothing at all, or you find yourself needing to go every few minutes. This is not a coincidence. This is anatomy. Your rectum and your bladder share a confined pelvic space. They are immediate anatomical neighbors. When the rectum becomes severely distended with a hardened mass, it physically compresses the bladder wall from behind. It pinches the space around the urethra. Urination becomes difficult, painful, and sometimes impossible. In severe cases, this urinary retention becomes its own medical emergency. Misleading symptom number 3, lower back pain. A deep, dull, nonspecific aching in the lower back. Most people assume they slept wrong, or their arthritis is flaring, or they overdid it yesterday. But when rectal pressure builds significantly, that pressure radiates outward, into the lumbar region, down into the hips and thighs. The connection to the bowel is not obvious, and that is exactly why people miss it. Lower back pain combined with any bowel irregularity is a red flag that deserves immediate attention. Misleading symptom number 4, sudden mental confusion in older adults. This one is deeply important for caregivers especially. Clinical evidence consistently shows that significant bowel obstruction in older adults can produce what looks like a cognitive episode: disorientation, unusual agitation, uncharacteristic confusion. This happens because of the systemic physical stress the body is under, combined in some cases with early toxic buildup from the stagnant waste. If an elderly person in your life suddenly seems mentally foggy or agitated without obvious cause, always consider their bowel status. Always. When it becomes a life-threatening emergency, 14 to 1800 hours. I am going to be completely direct with you now. A fecal impaction is not something to wait out. It is not a minor inconvenience, left untreated. It follows a predictable escalation, and that escalation ends in a place that no one wants to reach. Stage 1. The intestinal wall, which is living muscular tissue, becomes severely overstretched. Blood supplied to that tissue begins to diminish. The muscle starts losing its ability to contract. That section of bowel goes quiet. Doctors call this an ileus. The system is shutting down. Stage 2. The distension spreads upward. Higher sections of the colon become involved. Nausea begins. Vomiting starts. The abdomen becomes visibly swollen and tender. The person looks and feels profoundly ill. Stage 3. Bowel perforation. The intestinal wall has physical limits to how much it can stretch. When those limits are exceeded, and they can be exceeded, the wall tears open. When that happens, the contents of the bowel, fecal material, bacteria, toxic byproducts, spill directly into the sterile abdominal cavity. What follows is a condition called peritonitis, a rapidly spreading catastrophic infection. Without emergency surgical intervention, it is fatal. The window between serious but manageable and life-threatening emergency is not wide, and it closes faster than most people expect. These are your emergency signals. If you experience any of these, call emergency services or go to the emergency room immediately. Do not drive yourself. A rigid, bored hard abdomen that is painful to touch, fever above 101 degree F, 38.3 degrees Celsius, constant, worsening abdominal pain that is not crampy. It is relentless, complete inability to pass gas of any kind, vomiting that will not stop, sudden drop in blood pressure with cold, clammy skin, and confusion. These are not, maybe I should call my doctor tomorrow, symptoms. These are go right now symptoms. What to do right now, step by step, 18 to 2300 hours. Enough about what can go wrong. Let's talk about what you do about it. Starting tonight, if necessary. Step 1, stop straining. Completely. The very first instruction is to stop doing the thing that feels most instinctive. Stop straining. Stop pushing. Stop forcing. Straining with fecal impaction does not help. There is no version of this where bearing down dislodges a hardened rectal mass. What it does do is increase internal abdominal pressure, irritate already inflamed tissue, and risk creating hemorrhoids or small tears in the rectal lining. Straining harder is not the answer. Stop. Step 2. Glycerin suppositories. Use correctly. Your first at-home intervention is adult glycerin suppositories. These are available over the counter at any pharmacy. No prescription needed. Here is the crucial information most people don't know. For a genuine impaction in an adult, one suppository is rarely enough. One alone does not generate sufficient lubrication to soften and coat a large, dehydrated mass. The correct approach is to use 2 to 3 adult glycerin suppositories simultaneously. Here is the exact protocol. Position. Lie down on your left side. This is called the left lateral position, and it is important. It aligns the sigmoid colon and rectum in a way that allows gravity to assist the process rather than work against it. Preparation. Apply a generous coating of water-based lubricant to each suppository before insertion. The rectal tissue at this point is already irritated and inflamed. Dryness at this stage increases pain and makes insertion more difficult. Insertion. Gently but firmly insert all suppositories as deeply as possible. You want them making direct contact with or sitting alongside the hardened mass, not resting near the entrance where they will simply slide back out. Wait! This is the most important instruction. Do not move for a minimum of 30 minutes, ideally 45 minutes. The glycerin needs time to melt at body temperature. It needs time to penetrate the outer surface of the hardened mass. It needs time to stimulate the rectal wall into producing its own lubricating secretions. If you stand up at the 5-minute mark, you have accomplished nothing. After 30 to 45 minutes, rise slowly, go to the bathroom, and allow your body to work without forcing anything. Step 3, rest, warmth, walk, repeat. If the first round produces no movement, stay calm. This is common. Give yourself 1 full hour of rest. Stand up. Walk gently around your home. Drink a full glass of warm water. Warmth relaxes intestinal muscle. Then lie back down and repeat the entire suppository process, exactly as described. The first application frequently softens the outer layer of the blockage. The second round reaches the interior. 2 rounds together accomplish what 1 round alone cannot. Step 4. If home measures fail, go in. I won't be completely unambiguous about this. If you have completed 2 full rounds of this protocol, waited the appropriate time, and there is still no movement, or if you are experiencing any of the emergency symptoms I described, you need to go to urgent care or the emergency room. This is not defeat. This is a correct clinical decision. This is you taking care of yourself. At the hospital, the medical team has access to clinical-grade enemas that deliver larger fluid volumes under controlled pressure, reaching further into the colon to break the mass apart from above. They also have imaging tools, simple abdominal x-rays, to see exactly how extensive the blockage is and whether the bowel wall is at risk. Step 5. Manual disimpaction. In cases where all other measures fail, a specialist will perform what is called manual disimpaction. I want to explain this clearly because knowing what to expect removes unnecessary fear. The physician will physically break apart and remove the hardened mass using gloved, lubricated fingers. In cases where the impaction is severe or the surrounding tissue significantly inflamed, this is performed with appropriate sedation or anesthesia so that you feel no pain and the rectal muscles can fully relax. It is a serious clinical procedure, but it is a safe, well-established one. And the relief patients describe afterward, the immediate, dramatic release of pressure, is described consistently as profound. Clearing the blockage is essential, but if we stop there, we have only solved half the problem. Because without addressing the conditions that created the situation, you will be back here, probably within weeks. And after the second episode, the third comes faster. Here is how you protect yourself long-term. 1. Hydration is a foundation of everything. Water is the single most important variable in preventing stool from hardening. Your large intestine extracts the moisture from waste as its primary function. If there is not enough incoming hydration, there is not enough moisture in the waste stream to keep stool soft. The challenge for older adults is real. Your thirst reflex is genuinely weakened. You can be chronically dehydrated at a cellular level without feeling thirsty at all. The solution: do not wait for thirst. Drink on a schedule, 6 to 8 glasses of water spread through the day, and begin every single morning with a full glass of water before eating or drinking anything else. This stimulates the gastrocolic reflex, a natural wave of intestinal movement triggered by fluid entering an empty stomach. It is one of the most effective medication-free tools for encouraging regular morning bowel movements. 2. Physical movement directly drives intestinal movement. Your intestine is muscular tissue. It moves waste through rhythmic contractions. And here is something most people genuinely do not realize. Physical movement of your body directly stimulates those contractions. A 20 to 30-minute walk after meals, even a gentle, comfortable walk, has been clinically shown to significantly accelerate intestinal transit time for those with mobility limitations. Even gentle chair exercises, simple torso rotations, or seated leg movements help keep the digestive muscles active. Prolonged sitting, especially after eating, is one of the most underestimated contributors to constipation in older adults. 3. Review your medications with your doctor. This is non-negotiable. A wide range of commonly prescribed medications are known to slow intestinal movement. Opioid pain relievers, certain blood pressure medications, iron supplements, calcium at high doses, antidepressants, antihistamines, and diuretics. This does not mean stopping your medications. It means having a direct, specific conversation with your physician. Ask them, could any of my current medications be contributing to constipation? And if so, are there alternatives with less digestive impact? Many physicians do not raise this topic. Unless you do, you need to be the one who asks. 4. Be careful with stimulant laxatives. Stimulant laxatives, the kind that chemically force intestinal contractions, are useful in genuine short-term situations. But here's the danger. When they become a daily habit, the intestinal muscle begins to depend on that external chemical stimulus to initiate any movement at all. without the laxative, it simply does not contract. This is called laxative dependency, and it is far more common in older adults than most people realize. If you have been using stimulant laxatives daily for more than 2 to 3 weeks, please speak with your physician before stopping, and work together to gradually restore natural motility through the other approaches I've described. Establish a consistent bathroom routine. Your digestive system follows an internal clock, circadian rhythms just like your sleep cycle. The gastrocolic reflex, the natural wave of intestinal movement, is strongest in the morning, particularly within 30 minutes of waking and within 30 minutes of eating breakfast. Use that window every single day. Go to the bathroom at the same time each morning, whether you feel a strong urge or not. Sit, relax, give your body 5 to 10 minutes. Over 1 to 3 weeks, your body begins to synchronize to that schedule. Consistency is a training tool. Don't skip days. 6. Change your toilet posture. The human body was not designed to defecate in a 90-degree seated position with feet flat on the floor. Physiologically, a slightly squatted posture, thighs angled upward toward the abdomen, fully relaxes the puborectalis muscle, a sling-like structure that otherwise creates a natural bend in the rectal canal. A simple step stool placed under your feet while sitting on the toilet, raising your knees above hip level, can meaningfully ease the mechanics of evacuation. It sounds too simple, but for many older adults, particularly those with weakened pelvic floor muscles, this single change produces a significant, immediate improvement. Part 7. A message for caregivers, 28:00, 29:30. Before I close, I want to speak directly to those of you watching not for yourselves, but for someone you love and care for, an aging parent, a spouse, a sibling. Fecal impaction is disproportionately common in elderly adults who are bedridden, mobility limited, or living in care facilities. And the person who first notices something is wrong is almost always a caregiver. If the older adult in your life has not had a meaningful bowel movement in 3 or more days, is complaining of abdominal pressure or back pain, or seems unusually confused, agitated, or uncomfortable, do not assume it will resolve on its own. In frail, older adults, the intestinal walls are less resilient. The ability to communicate the severity of discomfort may be limited. The cascade of complications progresses more quickly. Practical steps. Offer warm fluids consistently throughout the day. Assist gently with movement or repositioning. Consider using a glycerin suppository early, at day 2 or 3 of no movement, not day 6. And if there is any doubt at all, contact your physician. A simple abdominal x-ray can confirm a fecal impaction in minutes. Do not allow embarrassment to delay that decision. The conversation may feel awkward. The consequences of silence are far worse. Let me leave you with the things I most need you to remember. A fecal impaction is a serious medical condition. It develops slowly, disguises itself with confusing symptoms, and can escalate to life-threatening complications if ignored. Watch for persistent rectal heaviness, overflow liquid discharge, difficulty urinating, lower back pain, and in older adults, unexplained confusion. If it happens, stop straining. Use 2 to 3 glycerin suppositories lying on your left side. Wait 30 to 45 minutes. Repeat if necessary, and go to the emergency room if home measures fail. For the long term, drink water consistently. Move your body daily. Review your medications. Avoid laxative dependency. Establish a morning bathroom routine, and use a small footstool. Your digestive health is not a minor detail. It is connected to your energy, your immune function, your cognitive clarity, and your quality of life. And it deserves the same attention and respect as every other part of your health. We talked about it today. And I hope you walk away feeling more informed, less alone, and fully equipped to take action. Take care of yourself. Drink your water. And I'll see you in the next one.